A patient comes to your clinic. He says he has hoarseness of his voice. You use a standard mirror to look down his throat. You see nothing. You send him home. This is a fatal mistake. 6 months later, he returns choking. A massive tumor has eaten his larynx. He will lose his voice box forever. All because you trusted an outdated tool. Listen carefully. Looking is not the same as seeing. Today we stop guessing. We are bringing our scopes. We are turning on strobe light. I will show you how to hunt down microscopic cancer before it destroys the larynx. Master this and you save your patient's voice. Miss it and you seal their fate. Do not look away. Let us begin. Hello friends. Before we begin, for those who are new to this channel, I am Dr. Parveen Ahlawat. I am a consultant at Rajiv Gandhi Cancer Institute and Research Center in New Delhi for over 12 years. I have been practicing and teaching oncology for more than a decade. I did my MBBS and post-graduation from CMC Vellore. Then I did my DNB at Rajiv Gandhi Cancer Institute and Research Center, New Delhi. I pursued a fellowship at Royal Marsden Hospital in London and have later undergone specialized training from United States. I have published almost 85 research articles including abstracts in PubMed Index international journals. In my previous lecture, I taught you how to do a thorough history and physical examination for a patient with laryngeal or hypopharyngeal cancer. Now, you must proceed with the actual clinical investigations. This slide shows the exact strict sequence of 11 steps for evaluating laryngeal and hypopharyngeal cancers. You must deeply understand that this is never just a random checklist. It is a highly structured pathway carefully designed to prevent dangerous staging errors. We can divide the entire diagnostic journey into 4 distinct clinical phases, each phase having its own steps. Let us begin with phase 1, which is your initial visualization of the tumor while the patient is still in OPD. Step 1 is your traditional indirect laryngoscopy. Step 2 is your modern rigid Hopkins endoscopy. During this step, you must strongly consider combining your examination with videostroboscopy and narrowband imaging. Now let us move to the phase 2, which focuses entirely on staging and definitive tissue diagnosis. This phase is where you establish your complete T, N and M stage. Step 3 is ordering your local cross-sectional images. You will typically use a high-resolution CT scan as your workhorse and as your default initial imaging modality. You may sometime order an MRI, not routinely, but as a problem-solving tool. Remember our golden rule. Imaging must always happen before you take any biopsy. Step 4 takes the patient for a direct laryngoscopy and biopsy. This is your ultimate anatomical mapping exercise to secure the definitive histopathological diagnosis. This is your last and the best time to completely and accurately map mucosal disease. If you have not done videostroboscopy and narrowband imaging earlier, you may do it now during direct laryngoscopy. Step 5 is mandatory pan endoscopy. You must perform a triple endoscopy to definitely rule out any hidden synchronous second primary tumors. Step 6 is your comprehensive metastatic workup. You must diligently establish a M stage early in your evaluation. The most frequent site for distant spread is the lung. You will typically order a contrast enhanced CT chest or a PET CT for advanced disease. Then we enter phase 3. In this phase, we will establish a vital, functional and supportive baseline. These patients often have severely compromised airways and severe swallowing difficulties. Step 7 is your laryngeal functional assessment, utilizing tools like FEES, VFSS or video fluoroscopy. Step 8 evaluates their nutritional status. You must actively consider early feeding tube placement to fight cancer cachexia. Step 9 is a thorough dental assessment and prophylaxis. This is a critical safety measure before starting any radiotherapy. Step 10 is a formal speech and swallowing assessment. This establishes a baseline to guide their long-term post-treatment rehabilitation. Finally, we arrive at phase 4, which ensures absolute systemic readiness for cancer-directed therapy. Step 11 is your rigorous pre-treatment fitness workup. You must run complete blood panel. You may have to do a pulmonary and cardiac assessment for these patients. You must definitely confirm their cardiopulmonary reserve is strong enough to safely tolerate aggressive therapies. Only after completing every single of these 11 steps are you truly ready to initiate definitive treatment. Also, do not change the sequence of evaluation tools. You must follow these 11 steps in sequence as shown in this slide. Let us start with the first step immediately after you have taken history and physical examination from the patient, and the patient is still with you sitting in OPD. We are going to see what are OPD based workup we need to do for patients who are suspected to have laryngeal and hypopharyngeal cancer. We are going to see indirect laryngoscopy, Hopkins endoscopy, Videostroboscopy and direct laryngoscopy. We are now moving into a very crucial phase of our outpatient workup for laryngeal and hypopharyngeal cancers. Up until now, we have discussed external physical signs and symptomatology in great details. But now we must focus our attention to the internal mucosal assessment. Internal mucosal assessment. This is where we directly visualize the actual tumor inside the patient's airway. In this section, we will cover everything you need to know about OPD endoscopic evaluation. We will start with the traditional techniques of indirect laryngoscopy, IDL. Then we will move to the modern gold standard, which is the rigid Hopkins rod endoscopy. Mastering these two techniques is absolutely essential for every oncology resident. They form the definitive foundation for your precise anatomical mapping and clinical T-staging. Let us understand how to properly execute and interpret these procedures in your daily clinical practice. As oncology residents, you must clearly understand the difference between what we feel and what we see. Let us first talk about physical palpation. Feeling the neck with your hand gives you a basic clinical starting point. It is highly effective for finding any large lymph nodes in the cervical chain. But feeling the neck from the outside has a major limitation. It cannot tell you anything about the superficial spread of the tumor inside the throat. This is exactly why we must move on to internal endoscopic evaluation. Direct visualization inside the airway is absolutely mandatory. Looking inside the throat gives you a clear and final anatomical map. It allows you to clearly see the exact mucosal extent of the disease. This precise internal mapping of cancer is the absolute foundation of your oncological T-staging. You simply cannot plan any curative treatment without seeing the actual tumor with your own eyes. Let us start with the traditional baseline of our internal examination. This is the Indirect Laryngoscopy or IDL. While it is largely obsolete for precise oncological staging today, it remains a fundamental clinical skill. You will use this daily for rapid outpatient screening in your clinic. Look at the first step on your screen regarding patient position. You must position the patient in the classic sniffing the morning air posture. Their head should be slightly extended and leaning forward. You will use a good headlight to properly illuminate the oral cavity. Next, we move on to the traction maneuver. You must hold the anterior 2/3 of the patient's tongue with a piece of gauze. Gently but firmly pull the tongue forward. Why exactly do we do this? This forward traction physically pulls the epiglottis forward through glossoepiglottic fold. This simple mechanical action completely opens up the supraglottic airway for your view. Now look at the third step. You will take a Garcia mirror, usually size 4, 5 or 6. You must warm the mirror so that it does not fog up from the patient's breath. Introduce the mirror and place it firmly against the patient's soft palate and uvula. Now you ask the patient to loudly say a high-pitched E sound. This is a very crucial dynamic step. Saying E actively elevates the entire larynx. It also brings the epiglottis even further forward out of your way. More importantly, it forces the vocal cord to adduct right in front of your eyes. This allows you to immediately check their gross mobility. Finally, look at the diagram at the bottom of the slide. Always remember the most basic rule of this procedure. The mirror creates a completely reversed image. The patient's left side will always appear on your right side. I am going to show you how to draw an indirect laryngoscopy diagram step by step. Examiners love to ask this in case presentations. You will be asked to draw a diagram of ideal view. This is a key practical skill for all residents. Before we begin, you must understand the most critical rule of this drawing. The view you are recreating reflects exactly what is seen through a circular laryngeal mirror. This means it is a perfect mirror image. The patient's left side will absolutely appear on your right side. Since the view is through a round mirror, start your diagram by drawing a simple circular outline. The first structure you will see is the base of tongue. Draw this located in the upper part of your mirror view. Just below the tongue base, draw the epiglottis. You should shape the epiglottis so it looks exactly like an upper lip. Next, we need to connect the tongue to the epiglottis. Draw the glossoepiglottic folds to make this connection. Draw one median glossoepiglottic fold directly in the center. Then draw the two lateral glossoepiglottic fold on each outer edge. The distinct open space formed between the median fold and the lateral folds are called right and left vallecula. Now move down to the lower central part of your diagram. This is where you will draw the true vocal cords. The precise point at the front where these two vocal cords meet is called anterior commissure. Directly posterior to these cords, draw two arytenoid cartilages. The open space lying exactly between them is the interarytenoid region. Next, connect the arytenoids back up to the epiglottis. These connecting folds are the aryepiglottic folds or AE fold. Located inside the posterior part of these AE folds, you must draw small nodules. These nodules represent corniculate and cuneiform cartilages. On each side, directly lateral to the aryepiglottic folds, sketch out the right and left piriform fossa, which are also known as piriform sinuses. Now return to the vocal cords. Just above the true cords, you must draw the false vocal cords, also known as vestibular folds. Looking deep below the true vocal cords, add a series of semicircles to represent tracheal rings. Finally, draw the post-cricoid region just behind the trachea. Immediately behind that area lies the posterior pharyngeal wall. When you are finally labeling all these structures, you must always remember our golden rule. The patient's left always appears on your right side, and you must draw accordingly. Make sure you clearly label the right and left vallecula, true and false vocal cords, and piriform fossae. Lastly, you must know how to properly document your dynamic clinical findings. To show normal vocal cord mobility, clearly draw bidirectional arrows on both cords. However, if the patient has a vocal cord palsy, do not draw any arrows on the paralyzed side. Instead, show a definitive cut mark or a slash straight across the affected cord to signify that it is completely immobile. Now let us discuss some critical limitations of this indirect laryngoscopy. You must clearly understand that a perfectly normal mirror examination does not rule out cancer. The physical optics of the flat mirror creates several mandatory blind spots within the larynx. Look closely at the image on your screen showing these hidden areas. Remember, there are 5 areas in the throat which remain hidden during most indirect laryngoscopies. First, look at the anterior commissure at the front of the vocal cords. This critical area is very frequently obscured by the backward overhang of the epiglottic petiole. This is a very dangerous blind spot because you can easily miss an early glottic cancer. Second is subglottis. Subglottis is lying directly below the true vocal cords. The steep angle of the mirror reflection severely limits your view deep into this space. Because of this angle, you will completely miss any early subglottic extension of the tumor. Third is the laryngeal surface of the epiglottis. While the mirror shows the posterior aspect of larynx beautifully, the anterior wall is completely hidden by its own backward curvature. Fourth is the laryngeal ventricles. Laryngeal ventricles are also entirely hidden from your view by the overlying false vocal cords. Finally, the fifth region is the extreme lateral edges, which represent the apex of piriform sinuses. During normal rest, the deep inferior portion of these fossae completely collapse. You cannot fully illuminate them and you cannot actively distend them using just a basic mirror. So in this view, you can see all four areas are hidden. Because of these severe optical limitations, we can never rely on indirect laryngoscopy alone for definitive oncological staging. Because of these severe limitations of indirect laryngoscopy examination, we have experienced a major paradigm shift in our daily practice. Look at the instrument shown on your screen. This is the Hopkins rigid rod endoscope. It has completely replaced the traditional mirror as our absolute gold standard for outpatient evaluation. We typically use a rigid rod with a 70-degree or 90-degree angled lens. This specialized lens provides brilliantly sharp illumination and high resolution magnification. You will introduce this rigid telescope using a very simple transoral approach. You apply the exact same forward tongue traction with a piece of gauze that you use for the mirror test. You then gently slide the metal shaft straight over the top of the patient's tongue. Notice how the lens itself remains completely suspended in the open airway looking down and forward. It never physically touches the posterior pharyngeal wall or the sensitive soft palate. This simple fact completely bypasses the severe gag reflex that makes the ideal examination so difficult. This means you can comfortably and thoroughly examine almost every single patient right in your clinic. We will now discuss how the rigid Hopkins endoscope helps us clearly see those dangerous blind spots. The first major advantage is the brilliant resolution and magnification. You must realize that early cancer does not always look like a large mass. This high definition view allows you to identify very small and early mucosal changes. You can easily spot early leukoplakia or erythroplakia. You will also clearly see abnormal neoangiogenesis such as feeding vascular loops. These tiny blood vessels are the very first sign of a developing cancer. Next, let us talk about the highly critical anterior commissure. We already know the traditional ideal mirror examination completely misses this area. But the angled lens of the rigid rod goes right past the hanging epiglottis. It allows you to look directly down and check the full length of both vocal cords. This is absolutely important for accurately mapping the early glottic cancers. Finally, let us look at the hidden subglottis. To see this deep space properly, you must use a specific dynamic maneuver. You simply ask the patient to take a very deep breath in. This action completely abducts the true vocal cords. When the cords open wide, your angled lens can look directly down into the airway. This gives you a very clear view of any early subglottic extensions. We just saw how the rigid Hopkins scope gives us a very clear view. But we also need to see how the tissue actually moves. This is called dynamic functional assessment. First, let us talk about stroboscopy. Here, you will ask the patient to say E very clearly. This specific test helps us check the mucosal wave of the vocal cords. Why is this wave so important for us? If you see that this wave is completely lost, it is a major warning sign. It means the cancer has already spread deep into the vocal ligaments or thyroarytenoid muscles. See here. This is vocal ligament and this is thyroarytenoid muscle. This simple test quickly helps you tell the difference between a normal benign polyp and a true early cancer. Now look at the right side of the slide. You must also check the deep piriform sinuses. Normally, these areas are totally collapsed and closed when the patient is resting. So you must ask the patient to puff out their cheeks tightly. This is called the modified trumpet maneuver or the Valsalva maneuver. The inside air pressure forces both the piriform sinuses to open up completely. This lets you see all the way down to the very bottom. It helps you find any hidden disease that you would normally miss. We will now discuss the systematic subside protocol. You must always follow a very strict checklist during your Hopkins examination. We will start with part 1, which covers the upper supraglottis. The first zone you need to check include the base of the tongue and the vallecula. You must look at these areas very carefully. Look for any signs of abnormal fullness or clear ulceration. See here, you can see a mass in the base of tongue. You must also check for any abnormal pooling of saliva. Pooling of saliva here is a major warning sign of a hidden tumor or a swallowing problem. Next we move to zone 2, which is the epiglottis. You must trace the exact border of the epiglottis step by step. Start looking from the front on the laryngeal surface. Then move your scope slowly across the free upper edge. Finally, follow the laryngeal surface of epiglottis straight down to the petiole. You cannot rush this part of the examination. An early cancer can easily hide along these curves and completely change your final staging. Let us move further down to zone 3. This area includes the airy epiglottic folds and the false vocal cords. You must check these structures to make sure both sides look exactly the same. If you see a swelling or a mass on only one side, it is very important clue. It strongly suggests that the cancer has already spread deep into the paraglottic space. Next, we move to zone 4 to examine the piriform sinuses. You must carefully check both the inner and outer walls of these spaces. While checking here, you must actively look for Jackson's sign. This simply means you see a pool of saliva sitting in only one piriform sinus. This finding is a major clinical warning. It clearly tells you that there is a physical block lower down in the throat. It can also mean that the tumor has deeply involved the tissues and affected the normal swallowing process. We will now move further down the airway to part 3 of our protocol. This brings us to the glottis and the subglottis. Let us look at zone 5 first. This is where you examine the true vocal cords and both the commissures. You must carefully check their normal pearly white color and smooth borders. You also need to watch their mobility as the patient speaks. But here is the most important advice I can give you for this area. You must focus very closely on the anterior commissure. This is the exact point at the front where the two vocal cords meet. Early cancers often hide right here and can quickly spread to the thyroid cartilage. Finally, we reach zone 6, which is the deep subglottis. You simply cannot see this area while the patient is just sitting quietly. You must use a specific trick to see it properly. You have to ask the patient to take a very deep breath inside. This simple action forces the true vocal cord to open as wide as possible. Only then your angled scope looks straight down through the opening. This is the only way to check for any hidden tumor spreading below the vocal cords. Now we will summarize everything we have just learned in this table. This table clearly shows why we have moved from the mirror to rigid scope in our OPD practices to visualize laryngeal and hypopharyngeal lesion. We are comparing indirect laryngoscopy, ideal, and rigid Hopkins road. First, think about the overall image quality. The old mirror gives up a basic two-dimensional view with very poor light. But the Hopkins road gives us a brilliant high definition and magnified picture. Next is the image orientation. This is a very practical point for your clinic. The mirror always gives you a completely reversed image. Your brain has to consistently flip the picture while you are examining the patient. But the camera processor of the rigid scope automatically corrects this for you. What you see on the screen is the exact real anatomy. Now let us talk about those dangerous blind spots. The ideal mirror frequently hides the anterior commissure. It also gives a very poor view of the deep subglottis. But the angled rigid scope gives us an excellent view of both these critical areas. We also discussed the mucosal wave earlier. You simply cannot check this wave with a plain mirror. But with a rigid scope, you can easily attach a stroboscope to check it. Finally, consider patient's comfort. The mirror physically touches the soft palate and causes a severe gag reflex. But the rigid scope safely rests on the tongue, keeping the lens suspended in the air. This makes the examination much more comfortable for both you and your patient. Let us look at the final point of our discussion on endoscopy. This is about keeping a proper record of what we see. Documentation is absolutely non-negotiable in today's practice. You cannot just look inside the airway, write few lines in the patient file and send them away. We must actively record every single endoscopy as a high quality digital video. Let me tell you exactly why this is so important. First, we need these videos to proper disease mapping and planning for treatment. Second, it is a huge help for our radiation oncology team. They use these digital recording for gross tumor volume or GTV mapping. It helps them accurately mark the target area for delivering radiation therapy. And third, we need these baseline videos for long-term patient follow-up. After the patient finishes their treatment, the tissues inside the throat changes a lot because of swelling or scarring. Having a clear original video helps us compare the old and new findings very easily. This is the only reliable way to quickly catch any early signs of cancer coming back. Let us now move to the next critical evaluation method for early laryngeal cancer. We are now going to discuss videostroboscopy in detail. Videostroboscopy. So far, we have looked at static deep tissue images. We have also discussed how to map the gross mucosal anatomy using direct rigid and flexible endoscopy. But you must remember that the larynx is a highly dynamic organ. During normal speech, the human vocal cords vibrate extremely fast. They vibrate at fundamental frequencies between 100 to 250 Hz. Your naked eye simply cannot see this rapid movement. Even a standard continuous light and video camera will only show you a stationary blurred image. This is exactly why we need videostroboscopy in our outpatient clinic. It is a specialized technique that uses a synchronized, rapidly flashing light. This creates a brilliant optical illusion for the examiner. It allows us to watch the rapid vibration of the vocal folds in apparent slow motion. As an oncologist, you might wonder why you need to evaluate voice dynamics. This procedure is never just about assessing voice quality. It is an absolutely crucial diagnostic tool to detect early microinvasion. It allows us to instantly differentiate a benign reactive lesion from an early T1 carcinoma. Let me clear a very common clinical misconception. Stroboscopy is not a special type of camera or a new endoscope. It is simply a highly specialized synchronized illumination technique. A highly specialized synchronized illumination technique. Look at the diagram on the left side showing continuous light. During normal speech, human vocal cords vibrate incredibly fast. They vibrate at fundamental frequencies between 100 to 250 Hz. A standard video camera only captures 30 to 60 frames per second. Because the camera is too slow, the rapid movement just looks like a stationary blurred wedge. You cannot diagnose early microinvasion by looking at a blurred image from the camera. Now see the diagram on the right side showing strobed light. Here is exactly how we solve this visual problem. We place a microphone on the patient's neck to instantly detect their exact fundamental frequency. The stroboscope then fires extremely rapid flashes of light. Importantly, it flashes at a frequency that is fractionally different from the vocal cord vibration. Each quick flash illuminates a slightly different phase of the consecutive vibratory cycles. Your brain then merges these distinct flashes together. This creates a brilliant optical illusion. It allows you to watch the entire glottic cycle as a smooth, slow motion wave. Now look closely at the video playing on your screen. This is a completely normal videostroboscopic examination. You must understand that these vocal cords are vibrating incredibly fast. They vibrate between 100 and 250 times per second. Your naked eyes simply cannot perceive this rapid movement. To evaluate this, you use a specialized strobe light synced to a microphone on the patient's neck. The light flashes at a speed just fractionally slower than the fundamental frequency of their voice. This precise timing creates a perfect slow motion illusion of the consecutive vibratory cycles. Now shift your focus to the surface of the vocal cord. Notice the beautiful, smooth, rippling effect traveling across the tissue. This is the highly critical mucosal wave. You are literally watching the loose, superficial mucosal layers sliding freely over the deeper, stiffer vocal ligaments and muscle. Look at how both vocal cords move symmetrically and fluidly. They meet perfectly in the midline to create a tight glottic seal. There is absolutely no stiffness and no tethering of the superficial tissue. If an early microscopic squamous cell carcinoma was hiding there, it would act like a rigid, deep anchor. It would focally dampen or completely destroy this smooth mucosal wave long before the entire vocal cord becomes fixed. But in this video, the mucosal pliability is completely healthy and normal. Here you can see an abnormal videostroboscopy where there is an ulcerated lesion over the almost entire length of one vocal cord. See how the motion of affected side of vocal cord is less. The vocal cord is not moving. Look at the opposite side. Vocal cord is moving nicely. Let us understand the exact anatomy behind the optical illusion. Look at the cross section of the vocal folds currently on your screen. The layers of vocal cord are epithelium, superficial lamina propria, which is also called as Rinke's space, intermediate and deep lamina propria. They combine to form vocal ligament and vocalis muscle. Notice how we divide the vocal cord into two main mechanical layers. The innermost layers consist of the surface epithelium and the underlying Rinke's space. You must remember that these layers are highly pliable and loose. Now look directly beneath it at the layers. This bottom layer is made up of the vocal ligament and the deep thyroarytenoid muscle. Unlike this loose, highly pliable layer, this deeper layer is very stiff and provides the main structural support. During normal human speech, that loose surface epithelium needs to slide completely free over the stiff muscle below. It is this exact uninterrupted mechanical sliding movement that creates the mucosal wave. This beautiful wave is exactly what you are looking for under that flashing stroboscopic light. Now let us see what happens when a cancer disrupts this wave on the next slide. We know that a carcinoma always originates in the surface epithelium. As this early T1 cancer begins to grow, it micro-invades downward through the basement membrane. It pushes deep into rhinky space and reaches the underlying vocal ligament. Now look at the large anchor graphic in the middle of the slide. This perfectly illustrates the exact mechanical problem we face. The invasive tumor acts as a rigid pathological anchor. It physically tethers that loose, pliable surface mucosa directly to the stiff, deep muscle layer. Because the mucosa is now anchored down, it can no longer slide freely during speech. This creates a highly specific diagnostic sign that you must actively look for. When you evaluate this patient under stroboscopic light, you will see a focal dampening or a complete absence of the mucosal wave right at the site of the lesion. This focal loss of the mucosal wave is frequently the very first and only clinical sign of early microinvasion. It happens long before you will ever see gross vocal cord fixation or advanced T-stage disease. These are the four completely different patients. Look at the first patient on the far left of the screen. This represents a classic benign lesion, such as a simple vocal cord nodule or a polyp. Notice how the pathology is strictly confined to the superficial epithelial layer. Because it is not breaching the basement membrane, the underlying mucosal wave will remain perfectly preserved and dynamic during the speech. If you look at the vascularity, you will only see normal organized patterns. Now look at second patient. This represents a very early carcinoma. The cancer has originated in the surface epithelium and has just begun to actively micro-invade through the basement membrane. Next, look at the third patient to see what happens as this micro-invasion progresses. This patient has a deeper T1A lesion that has pushed firmly into rhinky space. This creates the dangerous tethering effect we discussed earlier. When you evaluate this specific patient under stroboscopy, you will see a focal dampening or maybe a complete absence of the mucosal wave. Furthermore, their mucosal vascularity will appear highly atypical, chaotic, and disorganized. Finally, carefully examine the fourth patient on the far right. This patient presents with a much deeper, more advanced lesion. The tumor has invaded completely through the ligament and infiltrating the vocalis muscle. Because this deep muscle provides the main structural support, you are no longer just looking for a lost mucosal wave. You will likely begin to see gross impairment of vocal cord mobility or complete fixation. Your ultimate diagnostic goal is to definitely separate that first benign patient from these malignant cases as early as possible. Let us move to the actual instruments we use in clinic for doing stroboscopy. We will now discuss the actual instrument we use in the clinic. Rigid nasal stroboscopy is your absolute gold standard for doing stroboscopy. Rigid transoral stroboscopy. This shows the rigid Hopkins rod. We typically use a 70 or 90 degree angled lens. This rigid instrument provides the maximum possible magnification. It also provides brilliant light transmission. This unmatched optical clarity is absolutely mandatory. You need it to evaluate early T1A and T1B microinvasion lesion. You simply cannot compromise on resolution. You are hunting for very subtle mucosal tethering. However, this rigid approach has distinct clinical limitations. The metal rod sits directly inside the mouth. Therefore, you can only assess the patient speaks only vowels. You cannot assess vocal cord when you ask them to speak complex words. Furthermore, a severe gag reflex can completely obstruct the procedure. Now look at the instrument of right side. This shows the modern flexible distal chip scope. These digital chips are excellent. However, they still provide slightly lower light intensity. Their resolution is also lower compared to the solid glass rod. But this flexible scope offers one massive clinical advantage. You pass this thin scope through the nasal cavity. This completely bypasses oral trismus and the gag reflex problems. Additionally, the patient's mouth remains completely free. This allows you to dynamically evaluate the vocal cords. You can assess them during normal connected speech and complex articulation. But remember, your primary goal as an oncologist, your goal is to catch early cancers sitting on the vocal cord. You are not just evaluating speech physiology. Therefore, you must always attempt to use the rigid rod first. This gives you the maximum diagnostic detail. You should reserve the flexible scope strictly as a backup. Use it only for patients who physically cannot tolerate the rigid examination. We will now discuss another important evaluation tool. We are going to talk about narrow band imaging or NBI. You will frequently see patients with white or red mucosal patches on their vocal cord. We clinically refer to these as leukoplakia or erythroplakia. But you must understand a very important clinical concept. These are purely macroscopic appearances. Macroscopic. They do not give you a definitive biological diagnosis. This is exactly where NBI becomes your best friend in operating theatre. It allows you to look past the gross surface and evaluate the microscopic vascular biology. Microscopic vascular biology. A change in vascularity directly indicates a change in the underlying tumor biology. A benign lesion will typically have a normal organized vascular pattern, but an early squamous cell carcinoma will show highly atypical, chaotic and disorganized blood vessels. Finally, look at the strict rule at the very bottom of the screen. You must routinely combine your NBI evaluation with your stroboscopy. You must examine the lesion across multiple prospective angles using your angled rigid scopes. And critically, you must complete this entire assessment before you make your first surgical cut or biopsy. Once you start resecting, the surgical bleeding will completely absorb the NBI light. Once the surgical field bleeds, this brilliant tool becomes completely useless for you. Not many hospitals have this tool, but if you have it, it is a very useful tool. This slide shows how we clinically classify laryngeal lesions using narrow band imaging. These are pictures A1, B1, C1, D and E. These are our 4 standard white light views without narrowband imaging. The bottom row shows the exact same lesion evaluated under NBI. We are specifically looking at the intraepithelial papillary-capillary loops. Based on appearance of these intraepithelial papillary-capillary loops seen on NBI, we categorize all lesions into type 1 to type 5C. Look at the first column on the far left showing images A1 and A2. This is a type 3 lesion. Under standard light, you see a thick white plaque or leukoplakia. Under NBI, the underlying capillary loops are obscured and invisible. These are typically benign lesions such as chronic inflammation or hyperkeratosis. Now look at images B1 and B2. This is a type 4 lesion. Look closely at the NBI image at the bottom. You can clearly see the capillary loops as small, regularly arranged brown spots. This specific pattern indicates a precancerous state, specifically low-grade intraepithelial neoplasia. Now look at images C1 and C2. This is a type 5A lesion. Notice how the brown spots have become much larger and irregular and dense. Can you notice this? This is a major clinical red flag. It indicates a malignant transformation into high-grade intraepithelial neoplasia or carcinoma in situ. Move to images D1 and D2. This represents a type 5B lesion. The normal capillary structure is now completely destroyed. Instead, you are seeing twisted, expanded vessels that look like thick lines, worms, or snakes. Can you appreciate all these? This highly chaotic vascularity means you are dealing with a true invasive carcinoma. Finally, look at images E1 and E2. This is a type 5C lesion. The original capillary loops have completely disappeared. They are entirely replaced by massive, irregular and uneven new tumor blood vessel. This confirms a gross, fully invasive carcinoma. See how NBI classification is an incredibly powerful diagnostic tool. It allows you to accurately predict the microscopic pathology before you even take your biopsy. This is the overall imaging algorithm. We just discussed evaluating early lesion microscopically with NBI. But the gross presentation of the tumor strictly directs you what your next step should be. It tells you exactly when you need advanced cross-sectional imaging. Imagine you detect an early glottic lesion. The vocal cord is fully mobile. The lesion is strictly small and confined to the free edge of the vocal cord. In this specific scenario, you do not need a CT scan. Routine cross-sectional imaging here is an unnecessary waste of resources. Your rigid stroboscopy and NBI in the outpatient clinic are completely sufficient. However, look at the high-risk features on the right side of your screen. Perhaps the lesion is bulky. Perhaps it involves the anterior commissure, or perhaps it shows any subglottic extension. If you see any of these specific features, you must completely change your approach. You must immediately escalate to advanced cross-sectional imaging. You must order a high-resolution CT scan. High-resolution CT scan. Always request at least 0.6 millimeter cuts. Do not settle for anything less than 1.2 millimeter. Alternatively, you can order a contrast enhanced MRI in those particular scenario I explained you earlier. You desperately need this precise imaging. It allows you to confidently assess the deep paraglottic space. It also helps you definitely rule out any subtle cartilage invasion. You must secure this information before you plan your surgical resection. This brings us to the modern paradigm of managing early glottic cancer. It beautifully unifies your diagnosis and your definitive treatment into one streamlined pathway. Let us start with step 1 on the left side of the slide. Everything begins with a meticulous office or OPD evaluation. You must actively confirm microinvasion using your rigid stroboscopy. You must also carefully assess the vascular biology using narrowband imaging. If the clinical picture points clearly to an early squamous cell carcinoma, you must completely avoid redundant punch biopsies. Taking a simple punch biopsy in the clinic only delays treatment and complicates your final surgical resection. Now shift your focus to step 2 in the middle. This is your crucial pre-operative mapping phase. You must determine the exact superficial spread of the lesion. You must also predict the required deep margin before you ever make a cut. You achieve this by observing the exact focal absence of the mucosal wave under your stroboscope. Finally, look at the step 3 on the far right. This is where you proceed to transoral laser microsurgery or TLM. You take the patient to the operating theater for a complete one-stop procedure. You perform a definitive single-stage excisional biopsy. This brilliant approach gives your pathologist the entire intact tumor for a total pathological diagnosis. More importantly, it provides the patient with an immediate oncological cure. And it accomplishes all of this while safely preserving their long-term vocal function. These are some absolute rules for early glottic evaluation. These 3 rules summarizes everything we have discussed so far. First, the focal loss of mucosal wave is your most important clinical sign. Second, you must combine rigid stroboscopy with narrowband imaging. This specific combination is the non-negotiable standard for optical resolution. You simply cannot compromise on this when evaluating these delicate early lesions. Third, you must confidently omit advanced cross-sectional imaging for classic T1 lesion. If the tumor is situated purely on the free edge of a fully mobile cord, do not order a CT scan. It will not give you additional information. Instead, you must proceed directly to a single-stage excisional biopsy in the operation theater. This brings us to the end of our discussion on videostroboscopy. You must always remember that this is never just a simple voice assessment tool. It is your primary oncological weapon in the outpatient clinic. It allows you to detect early malignancy long before gross tissue destruction occurs. It accurately maps the true depth of the disease. And most importantly, it strictly directs you in choosing your ultimate surgical approach. So guys, we have just finished our detailed discussion on OPD based endoscopies. You now know exactly how to properly map the superficial mucosal spread of a tumor even when your patient is sitting in OPD. But what is happening underneath that surface? An endoscope can see the mucosal surfaces of larynx and hypopharynx, but it simply cannot see deep into the fat spaces or inside the cartilage framework. It cannot see what is happening beneath that mucosal surface. To find the hidden disease, we must look beyond what our naked eyes can see. This brings us to the highly fascinating world of local cross-sectional imaging. It is going to be a very big topic and hence needs separate class on it. Today what I'm going to do is skip imaging and jump to direct laryngoscopy and biopsy. Since many of you had just joined the residency program or are in early career of oncology, you might not have even entered inside the endoscopic room yet. But you must understand early on that direct laryngoscopy and biopsy is one of the most critical procedures you will learn to perform. It is the exact clinical moment we move from simply suspecting a cancer to definitely proving it. This procedure gives us the definitive anatomical mapping of the tumor. I want you to burn this concept into your memory right now. This procedure is never just about taking a quick bite of tissue and sending it to pathology. It is your ultimate opportunity to physically map the exact three-dimensional border of the tumor. The precise details you document during this scope will dictate the exact T stage of the disease. They will become the absolute blueprint for drawing your radiation target volumes. Ultimately, what you see through this scope will decide if you can safely keep their voice box or if they require a radical life-altering surgery. Let us look at the three pillars of excellence currently on the screen. These are your three non-negotiable goals every single time you perform the direct laryngoscopy. First, you must secure a definitive histopathological diagnosis. You need to take an adequate tissue sample to confidently confirm a histological diagnosis. In most scenarios, it is going to be the squamous cell carcinoma. But you need to be absolutely sure you are not missing something unusual like a sarcoma or a minor salivary gland tumor. Second, you must achieve precise three-dimensional tumor mapping. You are not just looking at the surface mucosa. You must physically determine the exact mucosal extent. This means manually evaluating all the critical tumor boundaries that your CT scan might have missed. Third, you must actively hunt for synchronous second primary. Never forget the dangerous concept of field cancerization. Because the entire aerodigestive tract has been bathed in the same tobacco and alcohol carcinogens, you must complete a thorough evaluation of the surrounding areas. You are never just looking at the primary laryngeal mass. Let us move to the next crucial step. Before you even introduce your rigid scope, you must securely manage the patient airway. Look at the airway management matrix currently on your screen. This is your exact clinical blueprint for safely navigating these highly compromised airways. Let us start with the highest risk scenario. If your patient presents with a stridor or a bulky T3 or T4 tumor, you must be extremely cautious. These patients are often using accessory muscles just to breathe. You absolutely cannot risk a routine general anesthesia induction. You must secure this airway with an awake fiberoptic intubation or a planned tracheostomy under local anesthesia. Now look at the second scenario for your standard cases. If the patient has normal airway patency, you will use a microlaryngeal tube. We typically select a smaller size, usually between 5.0 and 6.0 mm. This keeps the patient perfectly safe while giving you enough physical room to maneuver your rigid instruments. Finally, look at the third scenario. What do you do for early T1 or T2 glottic cancers or tumors sitting directly on the posterior commissure? In these specific cases, a standard tube will completely physically block your surgical view. You simply cannot map what you cannot see. To solve this, we utilize high resolution jet ventilation or apneic oxygenation. This highly specialized tubeless approach gives you an entirely unobstructed panoramic view of the entire glottic. During your rigid endoscopy, you must systematically evaluate these specific areas. Let us start with the anterior commissure on the top left. You must remember that Brolle's ligament fundamentally lacks a protective perichondrial barrier. A tumor located here can directly invade the thyroid cartilage very easily. This direct invasion will immediately upstage your patient's disease to a T4 stage. Now look at the subglottis on the top right. You must meticulously measure the exact inferior extent of the tumor from the true vocal cords. This exact measurement dictates the lower border of your radiotherapy field. It also tells the surgical team if a complex tracheal resection is required. Now look at the paraglottic space. While an MRI is best for evaluating deep tissue, your scope cannot assess for secondary mucosal bulging. If you see abnormal fullness in the false cord or ariepiglottic folds, it strongly indicates deep paraglottic invasion. Finally, focus on the piriform apex. This is absolutely critical for mapping hypopharyngeal tumors. If the tumor extends deep into the apex, it very frequently invades the cricoarytenoid joint. This deep invasion will permanently fix the vocal cord. It will completely compromise your ability to perform a conservative organ-sparing surgery. Once you have proper mapped all those anatomical danger zones, your next critical step is to do a biopsy from the lesion. Look at the principles of precision biopsy currently on your screen. You must follow these strict surgical rules when you take biopsy. Always take your bite directly from the underlying edge of the tumor. You want to sample the most active area of tumor. Next, you must always take a deep bite. You need to capture the underlying submucosa to your pathologist so that your pathologist can definitely prove basement membrane invasion. Finally, if you are evaluating multiple suspicious lesions, you must use separate instrument. You must use different or freshly sterilized forceps for each individual site to avoid any risk of false tumor upstaging. These are things you must absolutely avoid. Never take your biopsy from the dead necrotic center of the mass. If you do this, you will only yield non-diagnostic keratinized debris and the pathology lab will simply reject your sample. Do not perform a simple superficial stripping of the mucosa. A superficial scrape will completely miss the deeper invasive carcinoma that you are trying to confirm. Lastly, you must strictly avoid the use of excessive cautery. Excessive heat induces severe thermal artifacts, permanently destroying the delicate cellular architecture that your pathologist desperately needs to examine. Let us bring this entire clinical workup together with this final flowchart. Your precise surgical findings from the direct endoscopy dictate all of your next steps. You take your recorded mucosal limits, the exact depth of invasion, and the confirmed histological grade. This information directly translates into your clinical target volume or CTV. This is your ultimate radiotherapy mapping blueprint. It is strictly dictated by the subglottis and paraglottic extent you just carefully measured in the theater. Finally, this comprehensive map forces you to make the ultimate binary clinical decision for your patient. You must definitely decide if the patient is a safe candidate for organ preservation or if they require a radical surgical extirpation. Okay, now the next step in the evaluation of laryngeal and hypopharyngeal cancer is pan-endoscopy or triple endoscopy. Let us see the role of pan-endoscopy or triple endoscopy as part of workup for laryngeal and hypopharyngeal cancers. We know these patients carry a highly significant 10 to 15 risk of harboring a synchronous primary tumor. Because of this dangerous phenomena, simply looking at the primary laryngeal mass alone is not acceptable. You must systematically perform 3 distinct endoscopic evaluations. First, you must perform a comprehensive laryngopharyngoscopy. This is what we have already done called as indirect laryngoscopy. You will use rigid suspension to achieve complete bimanual freedom. You must utilize your 0 degree, 30 degree and 70 degree rigid Hopkins rod to secure angled mucosal view. Next, you must transition your focus and perform an esophagoscopy. This specific step is absolutely mandatory when you are dealing with hypopharyngeal index tumor. You must definitely rule out any hidden synchronous lesions down in the cervical and thoracic esophagus. Finally, you must complete your assessment with a thorough bronchoscopy to look at upper respiratory tract. You are actively looking for any direct downward tumor extension or indirect primary lesions. So friends, here I end my class today. In my next lecture, I will cover imaging for laryngeal and hypopharyngeal cancers. It is going to be a really long lecture, but very, very important. Thanks for watching. See you in next video. Signing off, Parveen Ahlawat.